Good morning. On behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome all of you to today's event from our Prevention in Focus webinar series. This is our first webinar of 2026, and we are thrilled to be back and excited about today's presentation. My name is Dr. Valerie Robinson, a health science policy analyst here at ODP, and I will be serving as your host for this session. For some background, this webinar series was first launched in 2021. It was created to provide a platform for hearing directly from prevention research experts and thought leaders whose work is driving impactful advances in the field of prevention research and public health. Today, we are delighted to have Dr. Lauren O'Connor, Dr. Josimer Matei, and Professor Gerald Mand. They're joining us today to discuss ultra processed foods and health outcomes, state of the research to inform practice. But before we begin, of course, I do have some housekeeping items and I'll go over some logistics for today's session. As attendees joined the webinar today, audio lines were muted. These lines will stay muted throughout the session. Please note that this webinar will be recorded, and an archive of the recording will be posted to our ODP YouTube channel in the coming weeks. There will be a question and answer session at the end of the presentations, and as stated on this slide, please feel free to submit any questions you have to the Q&A pod. And at any point in time, you may also use the Q&A pod for general commentary, questions for the speaker, or to request technical assistance. With that, I know we are eager to get to today's presentation, so at this time, I'd like to introduce Dr. Drew Bremer for opening remarks. Dr. Andrew, affectionately known to us as Drew Bremer, is the current director of the NIH Office of Nutrition Research. And since April 2025, he has also been the acting director of the NIH Office of Dietary Supplements. Drew is a board certified internist, pediatrician, and pediatric endocrinologist, and has a PhD in pharmacology. His areas of expertise include endocrine disorders, obesity, developmental origins of health and disease, and the role of nutrition in health throughout the life cycle. Prior to joining the NIH, Drew held academic positions at the University of California, Davis and Vanderbilt universities. Welcome, Drew. The virtual floor is all yours.
Well, thank you, Valerie, and thank you, everyone. It's always dangerous to give the floor to me. And Valerie, thank you for that nice introduction, which basically means I'm trained for a lot and good for nothing. But to kick things off, I do, on behalf of the Office of Nutrition Research, I really do want to thank the Office of Disease Prevention for their support of this workshop, as well as the organizers, the speakers, the participants, and all of you online for joining us today. It really is a pleasure. I always like starting my intros with gratitude, so I really want to give a call out to Allison Brown, Tanya Iger-Collins, and Brahma Kapla, as well as everyone on the logistical team that's behind the scenes for all the work they have done to really pull this off. So to everyone who's made this happen today, a profound thank you. As we all know, over the past several decades, profound changes in our food system really have reshaped dietary patterns, not just here in the US, but globally. And these shifts have coincided with rising rates of obesity, hypertension, and cardiometabolic diseases. And increasingly, research has begun to examine the role that ultra-processed foods, often characterized by high levels of added sugars, unhealthy fats, sodium, and industrial ingredients, may play in these trends. And as highlighted in this workshop, these concerns are particularly relevant for populations experiencing disparities in health outcomes, where access, affordability, and targeted marketing may influence dietary choices and exposures. A growing body of evidence also links high consumption of ultra-processed foods with adverse health outcomes. And as such, advancing disease prevention efforts will require a more comprehensive understanding of the underlying biological, behavioral, and environmental mechanisms through which ultra-processed foods, and in parallel, there's a critical need for rigorous intervention research to identify and evaluate effective strategies for reducing ultra-processed food consumption at both the individual and population levels. So this workshop really comes at a very pivotal moment, because while observational studies have provided important insights, many key questions remain. What are the causal pathways linking ultra-processed foods to disease? How do food environments, social determinants, and industry practices shape consumption patterns? And importantly, what interventions, whether clinical, community-based, or policy-driven, can effectively and sustainably improve dietary quality? Today's discussions are designed to address these questions through a multidisciplinary lens. By bringing together the panelists who are here today, with expertise ranging from epidemiological research and clinical trials to policies, we aim to foster a comprehensive dialogue that advances both scientific understanding and practical application. So at the NIH, we are committed to supporting research that not only deepens our knowledge, but also translates that knowledge into meaningful improvements in public health. And addressing the challenges posed by ultra-processed foods will require collaboration across sectors, innovative study designs, and a continued focus on health equity. So I encourage all the participants joining us today remotely and virtually to engage actively, challenge assumptions, and to explore opportunities for collaborations amongst each other and amongst your peers. As the insights generated during this workshop today will have the potential to inform future research priorities, guide evidence-based practice, and ultimately contribute to improved health outcomes for all populations. So once again, I do want to thank everyone for being here today. Your participation reflects not only the importance of this work, but also a shared commitment to advancing human health. I also recognize that being here today is a choice, and there is nothing more valuable than your time. And I want you to hear it directly from me how profoundly appreciative and grateful I am that you have intentionally chosen to spend your time with us today. That said, I am confident it'll be worth your while. So I promised Valerie and the team that I would make my remarks short. So with that, thank you again for being here. I look forward to what I'm about to learn, and I will turn the floor back over to Valerie. Valerie, the baton is back to you.
Thank you, Drew. Next, I'd like to introduce the moderator for today's webinar discussion, our moderator, Ms. Brahma Kautha, who will in turn introduce each of our presenters. Brahma Kautha is a health scientist in the Office of Disease Prevention here at the NIH. She is responsible for promoting collaborative research products and leading trans-NIH disease prevention efforts, including addressing health disparities and the leading risk factors for morbidity and mortality. As a health scientist, she contributes to efforts to identify prevention research gaps, to facilitate the development of concepts for scientific initiatives, workshops, and meetings. She is also a registered dietitian and co-chair of the NIH Ultra Processed Foods Work Group. Welcome, Brahma.
Thanks, Valerie. Thanks for that introduction. And thank you to Dr. Brummer for setting stage for the topic. I want to say we have an excellent lineup of speakers today. I will introduce all of them first and then give the podium to them so that there is no interruption in presentations. So our first speaker today is Dr. Josemer Matai, and Dr. Matai is the Donald and Sue Pritzker Associate Professor of Nutrition at the Department of Nutrition, Harvard Chan School of Public Health. She investigates the genetic, dietary, and psychosocial risk factors of obesity, type 2 diabetes, cardiovascular diseases, and allostatic load in racial and ethnic groups, as well as underserved and minority populations as a framework to explain health disparities. Her multiple projects include longitudinal cohort studies in Puerto Rico, mixed methods projects on diet, stress, and weight stigma, collaborations with epidemiological cohorts of Hispanics in the United States, and culturally tailored dietary interventions to prevent type 2 diabetes and heart disease in Boston and Puerto Rico. Her work extends to several Latin American countries through collaborative partnerships, and Dr. Matei promotes evidence-based policies and programs for chronic disease prevention in Puerto Rico and U.S. Latino communities. That's our first speaker. Now moving on to our second speaker, Dr. Laura O'Connor. Dr. O'Connor is a nutrition scientist and epidemiologist with expertise spanning randomized controlled feeding trials, dietary assessment methods, national nutrition surveillance, and evidence synthesis. In her current role as a nutrition and health program lead at the Agriculture, Food and Nutrition Evidence Center of Texas A&M Agri-Life Research, she leads evidence synthesis projects to inform public health initiatives, such as FDA's efforts to reduce childhood exposure to contaminants from foods and infant formula, the EPA FDA guidance on seafood intake during pregnancy, lactation, and childhood, and the WHO's guidelines for the management of obesity in children. In her previous roles at the National Cancer Institute and USDA, she contributed to systematic reviews for dietary reference intakes, served on the 2020-25 dietary guidelines for Americans, data analysis team, contributed to advancements to the NCI's dietary assessment tools, and led research efforts to methods of assessing red meat and ultra-processed food intake. That's our second speaker. And then moving on to our third speaker, Professor Gerald Mand. Professor Mand is a CEO of Nourish Science. He's an adjunct professor for nutrition, Harvard Chan School of Public Health, and a non-resident senior fellow at Trish College of Civic Life and Tufts University. He has extensive experience in U.S. public health and food policy and served in senior policy making roles for 3 presidents at USDA, FDA, and OSHA, helping lead landmark public health initiatives. In 2009, he was appointed by President Obama as the USDA Deputy Undersecretary for Food Safety. In 2011, he moved to USDA's Food and Nutrition Consumer Services, where he spent 6 years working to improve the health outcomes of the nation's $100 billion investment in 15 nutrition programs. During President Clinton's administration, Mr. Mand was senior advisor to the FDA commissioner, where he helped shape national policy on nutrition, food safety, and tobacco. He also served on the White House staff as health policy advisor and was Deputy Assistant Secretary for Occupational Health at the Department of Labor. During George Bush administration, he led the graphic design of the iconic nutrition facts label. That's the label, you see it on all the food products. The label at FDA, for which he received the Presidential Design Award. So before I turn the podium to our speakers, I would like to share that this webinar has been approved by the Commission on Dietetic Registration for up to 1.5 continuing professional education units, CPEUs. Registered dietitian nutritionists who would like to claim the CPEUs for attending the webinar must complete the learning assessment before downloading the continuing professional education certificate of attendance. Individuals interested in CPEUs are responsible for downloading and maintaining the record of both documents. The learning assessment and the certificate will remain available through June 1st, 2026. So we really appreciate the opportunity to hear from our speakers today, and we're really excited about the webinar. So now let me invite our first speaker, first presenter, Dr. Josemer Matai. Dr. Matai, over to you.
Thank you, Brahma. Everybody can hear me okay, and I hope you can see my slides. I want to thank the Office of Disease Prevention and the NIH for inviting me and having this opportunity today to share more about ultra-processed foods, which I will be referring as UPF during my presentation. What we know about them, what we don't know about them in terms of evidence with disease, and some considerations in the context of public health. So UPFs are everywhere these days. There are books, there are headlines, reports, and a plethora of research studies that have put UPF at the forefront of nutrition science and policy. But do we know exactly what we're talking about when we say UPF? And with that, I show you these two pictures and I ask you, would you be able to tell me which of these two cheeseburgers is made with UPF components and which one is not? Take a hard look at them. And to understand and to start on in identifying ultra-processed foods, we first need to look at the P in ultra-processed. If you open your fridge, if you open your pantry, you will find that most of the food that you have was manufactured somewhere. And most of this processing is intended. Sometimes it is necessary to make the food safe, to make it more apt for culinary uses, and to make it more ready for mass distribution, to make it more marketable. But it also includes steps that may modify the sensory properties of the original product. So let's take the example of the cheese in that cheeseburger that I just showed you. And with that, we start with milk. That's the raw, unprocessed product. It goes through several processes, gets pasteurized to decrease pathogens. We add some natural enzymes, color. And up to this point, this is a process that has been done for hundreds of years. We've been making cheese for hundreds of years. But then there are some industrial processes that may also introduce some specific components, such as stabilizers, preservatives, colors, flavors, to keep that cheese lasting longer in your fridge or to make it taste or look more appealing. Usually to generate higher profits because it's a more appealing product, more palatable. So this level of processing is precisely the base that we use to define UPFs. We have been recognizing the role of industrial food processing for the past 20 years, and this has led to several frameworks on how we define UPF. However, there is no consensus across these definitions. So these systems, they differ in the label and in the categorization of the foods. So sometimes you see 3 categories, sometimes you see 4 categories. And the naming of those categories is different across the definitions. The level of specificity of processing technique and ingredients within each category also differs, whether they include nutrients or not. So for example, some of them may refer directly to sugar, fat, sodium, some of them not, and whether they have quantitative measures or actual cutoffs for this definition. So for example, a limited amount of sodium or limited amount of sugars to consume. And today I will focus on the NOVA framework or the NOVA definition among the many that we have. Why? Because it is the most commonly used definition in nutritional epidemiology studies, and it's also the ones that all the studies that I'm going to be showing later use this definition. So NOVA was developed by Carlos Monteiro from Brazil, and it classifies foods into 4 categories based on the extent and the purpose of the processing applied to them. And something important is that NOVA does not pay a lot of attention to nutrition composition, rather that it is centered on the industrial processing, which may be interconnected to nutritional composition. So let's look one by one. NOVA 1 refers to the unprocessed or minimally processed foods. So this is where we process the food to facilitate storage, preparation, or consumption. And some examples include fresh fruit, vegetables, milk, raw meats. Then we have category 2, which refers to culinary ingredients. So these are products used to that we use in our kitchens and to prepare and season other food. So for example, vegetable oils, butter, salt, and vinegar. We have category number 3, and it refers to processed foods, where the processing is applied to increase durability and enhance the sensory qualities. And typical processed food might involve cheese, canned legumes, canned fruit and vegetables. And usually in nutrition epidemiology, we combine categories 1, 2, and 3 as non-UPF. That leaves category 4 as the UPF, the ultra-processed category. These are products that are often described as formulations that contain ingredients extending the shelf life, the palatability or the taste, profitability, and in many cases involve products of very poor nutritional composition. Some ingredients that sound familiar are emulsifiers, flavor enhancers, caloric and both calorie and low calorie sweeteners, modified starches, and protein isolates. Okay, so now that you know the definition, can we identify minimally processed cheese, a minimally processed cheese versus ultra processed cheese? And the answer is that it's not that easy. We don't have a readily available information or a label on foods saying whether it's ultra processed or not. So we need to look at the ingredients. So in the case of that cheese, a minimally processed cheese would contain only milk-based and milk-based ingredients, bacteria, natural colors, and an ultra-processed cheese will contain artificial colors, gums, emulsifiers, and several preservatives. Also, generally, UPFs tend to be cheaper than their minimally processed counterparts. So now that you know how to identify it, it can be a pretty tall order to identify a minimally processed or a non-ultra processed food. Why? Because they are so common in the food environment. 73% of the US food supply is ultra processed. And this was an estimation from a machine learning algorithm that accurately predicted the degree of processing of any food. And it is not surprising then that UPF comprise almost 60% of the total energy intake of US adults. And this is data from NHANES, and it shows that the consumption of UPF has increased over the last 2 decades in all segments of the population, with some differences across race and ethnicity, namely higher intake in individuals of Black heritage and lower intake among individuals of Latino Hispanic heritage. And at the same time, you can see that the intake of minimally processed foods, shown here in the squares, has decreased in the past 20 years. Now, importantly, UPF intake varies by country and population segment. So this is a systematic review that found significant differences in UPF intake across countries, with the ones shown in red here, Netherlands, the US, the UK, Canada, Australia, and Barbados having the highest intakes. Across all countries, UPF also was noted to be higher in younger populations, in people living in urban areas, and people who were not partner. Now, education, income, and socioeconomic status there was different associations depending on the country. And for example, in the US in particular, lower income and lower educational status were associated with higher UPF intake. So the authors of this study concluded that these differences might translate into large socio-demographic variations in the associations between UPF and disease, something that we're going to see soon. But they also highlighted the public health inequalities in UPF intake that exist across countries. So, while some of the differences might be explained by this access to UPF, they also reflect the power of targeted UPF marketing to specific subgroups. For example, in a study among school-aged children from 2013 to 2022, Even though food advertisements overall decline, children were still continuing to see more than 1,000 ads per year, and these were predominantly for unhealthy products. And a Roth Center report showed that despite, again, these declines, the food and beverage TV advertising was specifically targeting Black and Hispanic consumers. So against this backdrop, where do we stand then with the state of the evidence of how UPFs connect to disease? Well, there were several meta-analyses and systematic reviews published in the past 5 years, and they all reach similar conclusions. That is that the evidence is mostly suggestive of adverse associations with multiple body systems, but mixed across these conditions. So what does this mean? This is a systematic umbrella review of existing meta-analysis, so kind of like a meta-analysis of meta-analysis, that found direct associations between UPF and 71% of the health parameters that they studied. And this included mortality, cancer, mental health, respiratory, cardiovascular, gastrointestinal, and metabolic conditions. The most convincing evidence was for incident cardiovascular disease mortality, type 2 diabetes risk, and anxiety outcomes and combined mental health disorder. Highly suggestive or suggestive evidence was seen for all-cause or CVD mortality, overall cancer incidence, sleep outcomes, depressive outcomes, CVD and hypertension risk, and obesity. Other conditions had weak or no evidence. So let's delve a little bit deeper into two very prevalent and mostly preventable diseases. The first study on your left was a study from the atherosclerosis risk in community studies. It included adults aged 45 to 65. They collected data with a food frequency questionnaire and classified UPF, again with NOVA, and expressed by servings per day. They followed coronary artery disease events for 27 years, and they found that participants in the highest quartile compared to the lowest quartile of UPF intake had 19% higher risk of coronary artery disease. And this second study was adults about the same age, 40 to 69, in the UK Biobank. They assessed diet with a 24-hour dietary recall, and they follow participants for about 5 years for risk of incident type 2 diabetes. And they found a hazard ratio of 1.44, again, for comparing the highest quartile versus the lowest quartile of intake. Now, something important is that the authors of both studies also reported the percent that each type of UPF, or what we call subgroups, contributed to the frequency of UPF in the case of ARIC, or to the mean weight of overall foods in the case of the UK Biobank. And in both cases, we see that some foods, namely sugary beverages, baked goods, industrialized fats, and meat, were the top drivers of this overall UPF intake. So this started raising the question of whether these UPF associations that we saw before were homogeneous across this group, or if one of these groups were giving more weight to these associations. And the answer to that is that no, not all UPFs are the same or associated in the same way with disease. And one of the first studies to do this was done in the Nurses' Health Study and Health Professional Follow-up Study with type 2 diabetes at the outcomes. And the authors found that adults consuming the top quintile, so in the top extreme of total UPF intake, had overall, for overall UPF intake, 45% higher risk of type 2 diabetes. But these detrimental associations were only observed for some specific groups, specifically refined breads, sauces, spreads, and condiments, artificially and sugary-sweetened beverages, animal-based products, and ready-to-eat mixed dishes. On the other hand, cereals, dark and whole grain breads, packaged sweets and savory snacks, and yogurt and dairy-based desserts were associated with lower type 2 diabetes risk. Subsequently, a former doctoral student, now assistant professor at UT Southwest, Kenny Mendoza, sought to answer this question in my group with CVD prevention. and using the same cohorts, the nurses' health study and the health professionals. And he found that the hazard ratio for the highest versus the lowest overall was 11% for CVD and 16% for CHD. But you can see that these trends of magnitude are stronger for some specific group. And again, the differences is also very similar to what we observe with type 2 diabetes, with sugary sweetened beverages, red meats, and artificial sugar beverages conferring that higher risk, and cold cereal, savory snack, yogurt, disease, dairy-based desserts conferring an inverse association. Something that was also notable is that the overall intake of UPF was about 30% in this population, which tends to be lower than we have seen in the general population, given that this is mostly health professionals, more aware of their diet, probably. So we can imagine how much it could be the risk if for people who are consuming more UPFs. So importantly, our results of these divergent associations are mostly consistent with what has been observed in other cohorts assessing similar outcomes. So this is in the Framingham offspring cohort using hard CVD outcomes. This is in the EPIC cohort in Europe using where they analyzing cancer and cardiometabolic comorbidities both together, kind of the same results and the same patterns. Similarly, we observed this is an analysis that we did in the Hispanic Community Health Study of US residing Latinos, and also in EPIC with type 2 diabetes. So what this tends to be pointing is that the main offenders seem to be sugary beverages and animal-based products. But we still see some variation in the magnitude and the directionality of these associations for specific groups, and that might be because of the way that we're classifying the UPFs, as well as the way that we are assessing the diet. As I mentioned before, some studies have used food frequency questionnaires, some studies have used 24-hour re-goals. So in this example, when we were classifying UPFs in nurses' health professional, we relied on the food frequency items. We just have the items, specific items for packaged savory snacks. And so when we have 24-hour recalls and more specificity on the products, we had more items on that category. But the groupings may also change across studies. For example, in nurses' health study, we had a specific category for sauces, spread, and condiments. But in Seoul, these had to be collapsed with other UPF, and an intake was much lower, and we only had a couple of items. So one way to go around this is through feeding trials, as you can control exactly what is given. You know what people, what the UPF that you're given is exactly, as opposed to this variability that you can have in observational studies. Obviously, feeding trials and clinical trials pose many challenges, from the high cost to time to potential ethical considerations when we're talking about these ingredients. Nonetheless, there are a handful of clinical trials that have suggested a more causative link, and this is specifically with weight-related outcomes. So in the left, we have a pivotal trial by Kevin Hall, where participants were randomized to receive either an ultra-processed or an unprocessed diet for 2 weeks, and then immediately crossed over to the alternate diet for another 2 weeks. And it was ad libitum, so that means that they could eat as much as they wanted. And meals were designed to be matched for calories, energy density, macronutrients, sugar, sodium, and fiber. And what the authors found was that energy intake and weight gain were higher when people were on the ultra-processed diet compared to the unprocessed diet. And in fact, people were losing weight during the unprocessed diet. There's a more recent trial that also ran a crossover randomized, it was a crossover randomized diet, this time for 8 weeks. And this time they also provided dietary guidance. And what they found is that while both diets resulted in weight loss, this was more significant, so almost double for the minimally processed diet. So taken together, what this suggests is that consuming or limiting the consumption of UPFs in favor of a minimally processed diet could be a potential strategy for obesity prevention. So in summary, some points to remember is that UPFs are abundant, they are heterogeneous. The food formulation and the vast variety of food formulations that we have right now is part of why we have so many of these and why different such a assorted UPF range. But at the same time, that provides a potential point, a leverage point for regulation if we can regulate food formulation. There is mixed evidence on the outcomes, and that depends on the subgroup as well. That is suggesting that the myriad of mechanisms that might be playing a role. And also something to remember is that we have some social environmental factors at play, mainly socioeconomic and marketing. So as we move forward, we need more consensus on the definition of UPF and the classification of such. We also need to start disentangling single ingredients versus additive ingredients, or whether there's a synergistic effect of all of these UPF ingredients, as well as disentangling the actual effect of the nutrient versus the processing itself, which is a separate question. So we have many questions on mechanisms and policies, and for that, we will have our next brilliant panelist talking about mechanisms and policies. But I'm not going to leave you hanging, so I'll give you the answer of which burger is ultra-processed, and that will be the one to your left. Whether you purchase it at a food establishment or you prepare it at home, but remember that 73% of the food market right now is ultra-processed, so you can easily find this and make it at home. You would be eating more calories, more saturated fats, more sodium, more added sugar, and less fiber than if you made this burger yourself at home using minimally processed foods that have 0 UPF ingredients. And surprisingly, the price is about the same. So that means that you can have your burger and eat it too. And with that, thank you so much. I want to thank my funding sources, my group, especially Dr. Kenny Mendoza, who led a lot of this work, and reminding you to make good choices. And I pass it on to you.
Thank you, Dr. Matei. Excellent presentation. And also, thank you for telling us which one is better at the end. And we're off to our next presenter, Dr. O'Connor.
Thank you so much. Dr. Matei set my conversation up perfectly. So just some disclosures. Currently, I'm employed by the Evidence Center at Texas A&M, but I'll be sharing research that I conducted in my previous positions at USDA and NCI. But everything today is reflective of my personal perspectives only and not of any of the institutions. So I'm going to highlight some of the challenges that we face in nutrition science. It's going to be a little bit more high level, hypothetical. The challenges that we encounter when we're investigating causality and biological mechanisms, and then how those challenges are then amplified in ultra-processed food research. So randomized control trials are considered the gold standard for investigating causality and mechanisms of action. And to ground us in the challenges we face in nutrition, let's first start with a nice, clean pharmacological example. So this is a treatment trial of the infectious disease tuberculosis, which is actually, this is considered by many as the first randomized control trial ever. It's a very elegant and straightforward study design because there's a known single causative agent, it's the Mycobacterium tuberculosis. There's a demonstrated preclinical effect from animal and in vitro studies that streptomycin kills the bacteria. And albeit tragic, tuberculosis is a well-defined disease outcome that has clear symptoms and diagnostic criteria that's pretty consistent across the population. In prevention trials, especially in nutrition, it gets much more complex, especially for obesity-related diseases like cardiovascular disease and type 2 diabetes that can present in many different ways. So there are several biological pathways. There's not just one ribosome on a bacteria like there is here. There are many causative agents that contribute and interact. And so we're not just looking at one bacteria, we're kind of looking at the entire environment of the human. And the biggest challenge of all, and what I'm really going to dive into detail, is that foods and how we eat foods is much more complex than administering a drug or a placebo. So let's just take one food as an example. Let's talk about avocados. There are many known on the slide here, and even likely even more unknown compounds in avocados that can affect disease risk. Foods are also a source of energy measured in calories, which introduces confounding in nutrition research that we don't have to deal with in drug trials. So let's pretend that we're designing a study to assess how avocado consumption affects LDL cholesterol. Let's start with people who don't consume avocado. So this is the population that we're recruiting, and we randomize them to either eat avocados or continue not eating them. Those who started eating avocados are likely to increase energy intake because they're adding a food to their usual diet. And increasing energy, as we all know, will result in weight gain. But the no avocado group doesn't really have any changes in their health because they're just kind of continuing on their normal dietary pattern. So your results may suggest to you that avocado increases LDL, but in fact, it is confounded by the changes in energy intake and body weight. If we tweak just one tiny aspect of this study design and start with people who already consume avocados, so the interventions are the exact same, but the starting point is different. Now, the people in the no avocado group are removing avocados, likely potentially reducing energy intake, potentially losing weight. So you can actually reach the completely opposite conclusion with just that one little tweak in your study design. And in neither one of these studies did we actually isolate the effect of the avocado on LDL cholesterol. So I certainly oversimplified those examples for the sake of time, but Stephen Fleming and Tristan Paul did a systematic review about avocados recently, and they showed that half of the studies included in their review added an avocado to the participant diet and did not control for energy intake. And that's okay. It depends on your outcome. If your outcome is body weight or energy intake, then you want that to fluctuate. But if your outcome is more related to cardiometabolic health, it's best to control for that energy intake so you can isolate the effect of the avocado. And then in the rest of the studies, researchers instructed participants to substitute the avocado with another energy-containing food. So they adjusted for energy intake. And some even controlled additionally for macronutrients. You can control for micronutrients. There's all of these added layers of foods that when you're trying to drill down in a really simplified mechanism, you're trying to find one specific mechanism, which, in reality, it's not one specific mechanism. There's all these different things that you have to consider in your comparison. So you can control for energy intake with a comparison food, but this is, again, there's the comparison group or the comparison food that you're choosing can also affect your conclusions. So this is a systematic review of mine from several years ago, where we summarized effects of red meat intake on cardiovascular disease risk factors. And we stratified all the trials depending on what the replacement food was. So people were eating red meat compared to what? And studies that replaced red meat with plant proteins showed that cholesterol was higher with red meat intake. But the studies that had a poultry or fish comparison group, cholesterol was actually lower in the red meat group. So this demonstrates how your selection of your comparison food or your comparison group can completely change the direction of your effect estimate and your conclusion. So I've pointed out just a few decisions in nutrition research that can meaningfully change your research question, maybe without you even realizing it. And that will obviously affect your conclusion and translation of your research to the public. And there's so many more things to consider, and there's fantastic write-ups on this. There's a lot, several papers in Advances in Nutrition that I recommend you to go to. Oops. Looks like my slides might be frozen. Oh, there we go. So yes, there's all of these things to consider in nutrition research, and that was just with one food and one outcome. And so this becomes even more of a challenge in ultra-processed food research because we're not looking at one food or one food group like Dr. Matei showed us. We're looking at more than half of what people eat in the US. Also, Dr. Matei pointed out, well, that it's a vastly heterogeneous group of foods, ranging from things like cookies and hot dogs to things like tofu and whole grains and infant formula. So there's foods in here that we are confident are associated with good health outcomes, and things that we are, we suggest to reduce because they are associated with poorer health outcomes. So if we go back to our avocado example, rather than having our research participants eat a fresh avocado, which would be considered unprocessed or minimally processed, what if we had them eat a pre-packaged, ready-to-eat avocado spread or something that you buy in the grocery store, which according to NOVA would be classified as ultra-processed because of these additives that are bolded on the screen here. So any one of these additives, any one of these components of the avocado itself, these naturally occurring vitamins and minerals, any one of these can contribute to health outcomes, or it could be a confounding factor if not properly controlled for in your study design. So again, the challenges we face normally in nutrition science kind of explode when we start talking about ultra-processed foods, because there's so many other components to these foods outside of this raw ingredient. There's also dietary implications. Ultra-processed foods may affect the type of food. If you're eating an avocado spread, maybe you're putting it on a fast food meal versus if you were cutting it up at home, you're consuming it on avocado toast. There's potential mechanisms that are also behavioral in nature. So this is a long list of proposed pathways, and this is not exclusive. These are just that I pulled from a couple reviews. I'm breaking this down into components and characteristics of ultra-processed foods, and then the behavioral or biological mechanism of action that those components could be mediating the relationship between ultra-processed foods and higher risk of obesity and cardiometabolic disease. There's things in here like additives, texture, emulsifiers, diet quality. And so how do we tease out the many, many components of these foods that are interacting and affecting several biological pathways all at once, and likely in different capacities, depending on what else it's being consumed with? There's just a lot. There's a lot going on here, right? Like, it's a bit daunting. But I caution us to not be so reductionist in our thinking. In nutrition, we often want to find a silver bullet. I think we've realized now it doesn't exist. It's not likely one food additive or one ingredient or even one characteristic or component that is increasing our risk of cardiometabolic diseases. It's all of these things kind of interacting and the overall dietary pattern that they're a part of. So again, it's more likely going to be a complex interaction of all of these things. It's not going to be the same across all foods, like Dr. Matei showed us. And then when you're doing research and you're trying to solve this huge problem, you also then have to multiply these two columns by all of those nuances in study design that I went over. Because each one of those nuances in your study design can meaningfully change the interpretation of your research question and the usefulness of your conclusion. So basically, we end up with this like infinite number of studies that we need. Like, how are we going to do that? It's overwhelming, but I think there is a better place we can start. So a few years ago, my colleague and I, Kelly Higgins, when we were at USDA, we developed the research roadmap. And this identified key evidence gaps in ultra-processed food research. And one quote that I want to share from that roadmap, which I will admit I wrote myself, but it was agreed upon by the whole group, is that it would first be appropriate to conduct a systematic or scoping review on these questions, because research on these topics existed before they were viewed through the lens of ultra-processed foods. So in other words, processed foods, additives, all of these characteristics existed before we started saying the word ultra. So for decades, there have been public health policies and guidelines related to processed foods. This is just a couple examples. Make half your grains whole, recommendations to reduce processed meat for cancer. And because we have these policies and guidelines, that means that there is also decades of research underlying these policies and regulations that existed, again, before the introduction of the term ultra-processed in 2009. So I'm going to ask everyone to just kind of take off your ultra-processed goggles for a moment and look at this kind of overwhelming equation in a little bit of a different light. So completely ignore the term ultra-processed. Look at the list of components and characteristics of these foods that have been hypothesized by many to link them to negative disease outcomes. A lot of these things look very familiar to us. These are topics that we have years of research on already. So I'm going to go through a couple examples. Fructose, one hypothesized component of ultra-processed foods that is hypothesized to increase risk of disease is fructose. So I learned about the health effects of fructose back in grad school. So I know there's ample evidence on this topic. And a quick PubMed search related to cardiovascular disease, quickly proved me right. Another item on that list is whey protein. There are randomized control trials, actually, several well-done randomized control trials about the health effects of whey protein, most of them suggesting positive health effects. And so we know we have randomized control trials, and we have systematic reviews of randomized control trials. And actually, we're on to the next level where we have umbrella reviews of systematic reviews of randomized control trials. This is telling you we're getting to the point where we have a lot of evidence on this topic. There's not the word ultra processed anywhere in there, but if we think that whey protein is a mediator or a biological mechanism of action of how ultra processed foods are affecting health, there is literature here that we can go to. Rick Mattis also has an excellent review from 2023 about several of the proposed mechanisms in that list. So I'm not going to get into the details here. The point is that there's a lot of relevant evidence out there. And I think at this point, it's more of a matter of getting organized and making it accessible and easy to use for everyone. It's a daunting task, but it's not impossible. So at the Evidence Center, we conduct evidence synthesis projects so that we can equip decision makers with the evidence needed to inform policies, guidelines, and future funding directions. And so we're faced a lot with very large evidence base and trying to distill them down into something usable or looking for research gaps, much like we need to do with UPFs. So this is an example of a project led by one of the analysts in the program that I lead, Dr. Rupal Trivedi. She led an enormous scoping review where her team screened over 70,000 articles to identify greater than 10,000 articles that were related to heavy metals in foods. And she organized all 10,000 plus articles into this really cool interactive evidence map that organizes the research by heavy metal. And then you can see how many studies there are. You can see the blank cells, which tell you there's no evidence there. And then even cooler, if you click on one of those cells, you can see and download all the citations. This is an EpiMapper. So obviously, I'm not talking about heavy metals today, but something like this could be done with UPFs. It'd be a large effort, but it would help us kind of organize ourselves and really focus in on where do we really not have evidence and where do we have some evidence that we could maybe repackage or repurpose or just kind of look through in a different light. So you could conduct a large scoping review of the existing literature. You could organize it. You could, have it by animal model, randomized control trial, all of these different things. It'll just kind of help, I think, the field really kind of come together and have a resource to use to help prioritize the future of research. So another way to advance our understanding on ultra-processed foods is to look at dietary patterns. And to not be so kind of single track minded, because it's likely a combination of all of these different things working together, and that's essentially a dietary pattern. So when I was at NIH, and Dr. Matei showed this study as well, I collaborated with Kevin Hall using samples from his first randomized control trial on ultra-processed foods, in which 20 people stayed at his research center for a month. The participants all ate a dietary pattern that had 80% of energy from UPFs and then 0% of energy from UPFs, which he called the unprocessed dietary pattern. And these were consumed in random order. And we compared the metabolites in the participants' blood and urine after each 2-week dietary intervention. And if you're unfamiliar with metabolomics, it's essentially kind of a snapshot of all the tiny, tiny, tiny molecules that are roaming around in our system and how they're influenced kind of by external exposures in our environment as well. So this figure is a little busy, but let me walk you through it. It shows the individual metabolites listed on the left that were consistently different between the two dietary patterns that the participants consumed. And it's consistent across all biological samples. The color of the triangle shows you what larger class of chemical compounds the metabolites fall under. And if the triangle is pointing down, then the concentration of that metabolite was lower after the ultra-processed dietary pattern. And if it's pointing up, then the concentration was higher. So a couple notable findings here. We see that metabolites related to benzoate metabolism and acesulfame were higher after the ultra-processed diet. This was really exciting because it's a very logical finding. Sodium benzoate and potassium benzoate are commonly used preservatives in the US food supply, and then acesulfame is a marker of artificial sweetener intake. So as you learned from the previous presentation, these are all hallmark characteristics of ultra-processed foods. So it makes sense that these are higher after consuming the ultra-processed dietary pattern. Another really interesting pattern was that metabolites from fruits and vegetables were lower after consuming the ultra-processed dietary pattern. But this is not shocking. If we look at some of the photos that Kevin has in his supplementary material, which I think is a fantastic thing to do for controlled feeding trials, is let people see the food. You can see that the unprocessed dietary pattern was very rich in fruits and vegetables, whereas the ultra-processed dietary pattern basically had none. So overall, again, we found some really strong and logical biological signals of these specific dietary patterns. But this study really just shows one way to eat an ultra-processed dietary pattern. But in the real world, there's an infinite number of ultra-processed dietary patterns that could be consumed. So we conducted a similar analysis using blood and urine collected in the iData cohort, which is a free living cohort of older adults. And there's lots of great findings here, but the one that I want to pull to your attention is the persistent pattern that people consuming more ultra-processed foods consumed less plant-based foods, specifically fruits and vegetables. And we know that plant-based foods are a strong indicator for overall diet quality. So, we're thinking all these little tiny mechanisms, this additive or this specific coloring agent. But I encourage you to kind of pull back a little bit because diet quality is definitely still a contending explanation as to why ultra-processed foods are associated with so many diet-related chronic diseases. Ultra-processed foods could be displacing energy, but should otherwise be used to consume healthier foods. So I'll leave you with some thoughts of kind of how to continue to capitalize on data from really expensive and highly controlled, well-done randomized controlled feeding trials. One thing, don't ignore the xenobiotics. Those are external exposures, and they're called unknowns a lot, and a lot of times they kind of get thrown out, but they might be really important signatures that we should look more into. Also including the addition of foodomics. Foodomics is essentially a metabolomics analysis of the foods that were consumed. So this is a proof of concept paper by Emily Hill that used data from an old trial of mine that was conducted at Purdue with Wayne Campbell. Emily identified compounds that were specific to salmon and then measured those same compounds in the plasma of the participants who ate the salmon, and then looked at those associations between those compounds and health outcomes. So this allows us to better trace compounds or metabolites or metabolism of those compounds from the food all the way to the health outcome. And it kind of removes some of the noise from external exposures as well. Another thing to consider is developing data repositories or research consortiums to combine data across many randomized controlled feeding trials, because these are so expensive and timely to do that we want to maximize every little bit of data that we can. So this is a schematic of a project that I led while I was at USDA with my ORISE fellow, Dr. Aaron Yerke. We took plasma samples from 4 controlled feeding trials and ran metabolomics across all the studies together. These studies have very rich dietary data. Most of them are controlled feeding trials. They have a battery of cardiometabolic health outcomes, and now all have metabolomics data that can be used to explore questions related to ultra-processed foods, because there's a variety of different ultra-processed foods consumed across these dietary patterns. And this is just an example I show of how collaborations across trial researchers can really lead to meaningful, enriched data sets for a fraction of the cost of doing it from scratch. So I hope you walk away today with an understanding of the challenges that we go through in nutrition when we're trying to investigate mechanistic and causal research, and why collaboration and trying to capitalize on existing data is so important, especially in ultra-processed foods when there's just this plethora of potential outcomes and mechanisms and combinations of mechanisms that we're facing right now in a challenging funding environment. And this is my email address. If you want to connect, feel free to do that. And lots of QR codes to the Evidence Center as well. And now I will pass it along to Dr. Mand.
Well, thank you, Lauren, and thank you and Josie for outstanding presentations of the science, which is so critical as to this issue and really fundamental in our ability to make progress and to move to policy, which everyone is very interested to see where ultra-processed food policy is heading. And that's what I'll speak about now in my presentation. So to look at policy, it's really, what problem are we trying to solve is a really important place to start. So if you're working on policy, it's for a purpose. And the purpose of policy in public health is to improve health. And in this case, the need for policy is underscored by the current crisis that we're in. And so most of the audience will be familiar with these snapshots. You can see on the left, life expectancy in the US versus other wealthy countries. This is a pattern that started in the 80s and 90s where we started to drop behind. And you can see that the United States among wealthy countries is last in life expectancy and last by a lot, sort of maybe a standard order of magnitude last. And not only are we last, but you can see that sharp dip around 2020. That's COVID, and you can see how the U.S. did much worse than any other country with COVID. And you can see we've recovered some, but we're still well below where we were. And as troubling as our shorter life expectancy is, and why that is the rise in childhood obesity. And so that's been quite sharp, and indeed it's become difficult in America to raise your child to 18 without a food-caused chronic disease. So it's these crises, really a point where our house is on fire, that's leading to interest in ultra-processed food and the need for a policy. And I'll also underscore it with these maps that many have seen. These are the CDC maps to show, though, that by 1990, there really wasn't a single state in America with a 15% obesity rate. And as you can see, by 2000, it's changing. By 2010, it's changing even more. And indeed, by today, every state. So in 1990, 30 years ago, there wasn't a single state with a 15% obesity rate. Today, every state is over 30, most are over 35. And overall, as a nation, we have an obesity rate of at least 40%. And I say at least, if you look at other measures, this is based on BMI. If you look at waist circumference and BMI together, you get estimates as high as 70% of the population is obese. And, so the big question is what happened? Like, what happened between 1990 and today? Certainly our genetics hasn't changed. And so that's a question we're trying to understand. And you look at this point, this is the point in 1990 where we're below that rates, and you can see what's happened. Again, this is just circumstantial, but you can see how much ultra-processed food manufacturing has changed from where we were then to today. And it's only increasing, and you've heard the numbers about that. So as a result of that, we're sort of in a moment of ultra-processed food policy. And though I don't highlight per se, it's about MAHA. So Make America Healthy Again is really a big reason why we're having probably this meeting, why the debate's there. RFK Jr. certainly deserves enormous credit for making these issues a priority. And indeed, many are familiar with the MAHA first report, which really put this in sort of in the center of discussion and policy. And that report did some very very large and historical things. One, it identified that, child health should be our focus. But second, it said the root cause of today's health problems, the ones I illustrated before, is the U.S. Food industry. And indeed, the report cites ultra-processed food more than 40 times as the reason for today's crisis. But what's also interesting in this moment, and for a policy discussion, some may know a concept called the Overton window. It looks at, as you can see here, policies go where people on both sides think they're sort of unthinkable, to all of a sudden they become more and more toward popular, and then they become policy. And I think I would say that we are in one of those Overton windows now for food, nutrition, and health policy, and particularly around ultra-processed food. And indeed, you have a story here which is talking about how, wait, wasn't this once a Democratic issue? Indeed, I worked for Michelle Obama at USDA, and her work, we were working on this. We couldn't get anything done because we got some important things done, school meals, but many of the things we couldn't get done was because Republicans uniformly were against that. Indeed, I'll touch later on the SNAP pilots. I tried for 6 years to get a state to do a SNAP pilot. I couldn't even get a Republican governor to talk to me because it was Michelle Obama's issue. Today, 20 Republican states are doing that. So remarkable change in the parties and how they view that issue that gives us this sort of Overton window we're in. And so why is that? So let me show you this chart. As you can see here, this is the average family income in America. This was done around a little after Obamacare passed, looking at why healthcare costs are so expensive in America, what we're going to do about it. So you can see that top line is the average family income in America. The bottom line is sort of out-of-pocket expenses. And you can see in this chart, and these are numbers that everyone agrees with, right? We know what healthcare costs, premiums, out-of-pocket expense are. We know what the average family income. We know the trends on that. We can plot those. And you look forward and you see that in this study by 2030, now this was about a decade ago study, but by 2030, these lines will cross. Now that can't possibly happen. It can't be that just healthcare premium out-of-pocket expense is the average family income in America. But what this chart shows you is how little time we have to act. I think Obamacare pushed the 2030 out a bit, but not that much. And so sometime in the next decade, we have to fundamentally bring down healthcare, reform our healthcare system, probably pass something that's equivalent to Obamacare to deal with these skyrocketing healthcare costs that are simply crippling our nation, particularly our state governments. Another thing, military readiness. This is a group of 700 actually former admirals, generals, looking at one issue, one thing they care about: military readiness in America. This is a series of reports they put out where the number one threat to military readiness in America is childhood obesity. And so it's that, it's the healthcare costs, the military readiness that has really, I think, Democrats care about those issues as well, of course, but really has moved the issue, Republicans in particular, where this has become an equal priority for them. And as a result, we're in this sort of Overton window where we can make policy in this space. Now, for an administration and indeed food and nutrition policy, generally the number one government document on food and nutrition policy is the dietary guidelines. And RFK had the good fortune of coming in a year where the dietary guidelines were due. And indeed, based on tradition, he was given the pen to write them. And alternate dietary guidelines that would have gone to the Secretary of Agriculture. So he comes into office with this extraordinary opportunity to shape the dietary guidelines. And indeed, he has, and particularly on this issue of ultra-processed food. So to remind people, just recently we had the scientific report of the Dietary Guidelines Advisory Committee, and they looked at this issue. Indeed, I think Secretary Vilsack put it on the agenda that they should make a recommendation on ultra-processed food, but they didn't. They ended up saying that the evidence was limited, not because they had studies and the evidence was limited. It's mainly what we've heard before. Not a lot of studies have been done, and so the evidence was considered limited, and there was no UPF recommendation. And so it's fair to say that had Biden stayed in and there was dietary guidelines under a Biden administration, they probably would not have mentioned much about dietary guidelines, about ultra-processed food, other than to say that we need more research. But instead, we have the new dietary guidelines of 2025 to 2030, and a top recommendation. Well, first of all, the overall thing, as you can see, it is branding, it is eat real food, which is another way of saying don't eat processed food. And then it limits, it gives it a new name instead of ultra highly processed food, but it says to limit highly processed foods. Now, there's a qualifier on that, which I'm going to touch on in a second as well, which is limit highly processed foods, particularly added sugars and refined carbohydrates. And that's really critical to policy going forward. And so, as many of you know, right now we're in the midst, in fact, we're waiting. There have been stories more and more in the press over the weekend, the New York Times, about this definition that FDA is trying to come up with ultra-processed foods, something that I think is an impossible task because of the state of the science, but nevertheless, people are trying to come up with it. They're going to get it wrong because we don't have the science, and there's going to be only more confusion. But nonetheless, I get why people want to do it. You've heard from the other speakers why we would need a better definition, so I understand the effort. It's just, I think it's sort of doomed. But there's another opportunity that's here, and this is from Dr. David Kessler, the FDA commissioner. He's put a petition. Interesting, much like the dietary guidelines, he talks about highly processed foods, refined carbohydrates, and he's sort of singling out a particular class of ultra-processed food, these highly processed, refined starches, as the principal problem, the things that are most behind the obesity and diabetes I highlighted at the beginning, and saying we should start there. And I think that's an important place to begin. Now, as we also heard, a big problem here is science, and we need science. We really need something equivalent to the Human Genome Project to better understand our food and why it's causing health. If you go back, the earlier charts I showed, again, this all happened over a 30-year period. What changed over those 30 years? I think what we're seeing is most likely what changes our food. We went from eating real food to man-made food. That shouldn't be a problem if the man-made food was based on solid science to make sure that it was still allowing us to thrive and didn't make us sick, but the science wasn't there. Now, hopefully that was going to change. A big plank in the platform of MAHA, as you can see here. This is from a Wall Street Journal op-ed that RFK wrote when he became endorsed Trump. And he said that he's going to put half of the research budget of NIH into areas like nutrition to look at chronic disease, which was something that I think many of us were very excited about and hopeful about, and ability to finally make our progress here. But as we see here, this is from the 2025 budget. You can see the Office of Nutrition Research, who I'm grateful for having us here today. But you can see in the Office of Director, this is up a little bit since then, but you can see the budgets of the different offices. You can see here, it's less than $2 million. It had been that way for several years, despite efforts to increase it. And just to put it in perspective, a few above that, you can see the Office of Dietary Supplements, which one would think might be a subset of nutrition. But indeed, it's, more than 20 times larger, which is kind of nuts. But that's where we are. Now, in terms of science, what's needed, what we have to do, I'm just going to give you a couple of snapshots, work that's going out there that shows you how little we know, though, I think Lauren did a great job saying we know more than we think, but, she touched on this a little as well. So this is a researcher, a colleague at Harvard, Julia Menichetti, who's looked at the nutrition dark matter that was referenced in some of the slide. And this is just looking at one product. So overall, what we know are our studies of nutrition and such, there are 188 nutrients that USDA looks at, but that's out of 140,000 compounds in food. And here Julia looks at just taking garlic, there are 69 nutrients according to what the nutrition field, the nutrient model uses. But really the NOVA model, which expands to all of the compounds in foods, just in garlic, there's 6,800. And what Julia is doing, which is really terrific research that needs to be supported, but then she's using AI to match those compounds that we know as nutrients and the things that we know. She's looking at those molecules and comparing them to databases of small molecules from pharma and seeing how many biologically active compounds there are. And she's finding out that there are a lot of biologically active compounds in that dark matter that we really need to understand if we're going to understand the health effects of UPF. I apologize that in downloading these slides onto this program, it got changed a bit, but the headline should be, the top title should be Collective Cell Organization as a Biomarker to Reveal the Effects of Food Additives on Tissues. And this is a work of colleagues at Rockefeller University, Amy Shire, Alan Rodriguez. Their whole career has been based on looking at how, the miracle of life. How do you go from one cell? How do they organize themselves and become an organ? It's a very different way of looking. We look at testing chemicals in food and generally in the environment. We use sort of a model at the molecular level, molecular damage to DNA, cell toxicity, all super important work, but it's only one view of how it may be affecting health. They look at how it affects how cells organize. And they got my attention when they gave, the audience with familiar with aspartame. This is a study they did where they took the control, they put aspartame, they watched how the cells organize themselves. It still produced a functioning organ, but the cells organize completely differently. And what they don't know is, does that have a health effect? And it probably does. And it's the kind of research we're not even doing. And this really points to the need that we really need to sort of reinvent how we do the review of toxicity in chemicals. So last year, I joined 70 of my scientific colleagues. We sent a letter to the NIH director. This was our prescription of what needs to happen to support nutrition research and to really set the foundation for sound policy. We need to invest at least $120 million in the NIH Office of Nutrition Research. President Biden requested it, got zero because of food industry lobbying. We need a state-of-the-art research facility to do randomized trials like Kevin Hall did in scale. We need to be able to do them in months, not years. We need to do many of them, not one. The NIH overall nutrition budget needs to be increased to $4 billion, and we really need a National Institute of Nutrition. And we need all of that because, we need that because, looking at policy, so the dietary guidelines really affect a couple key areas of nutrition policy. One, by far the most important and most impactful, is going to be the school meal standards. On the left, you can see something we did when I was there doing with Michelle Obama. We did the increased school meals standards, went from a 58 healthy eating index score, really a failing score, to 82 in just 3 years, which just shows you the power of USDA's programs and the ability to shape that. And instead, we did that. We expected sort of more of the meals on the left. We ended up with the meals on the right. And the reason for that is because the standards we set were 100% nutrient based. So you can get, it's all nutrient driven. You get a healthy eating index score of 100. In fact, someone's done a study showing, a healthy eating index score of 100 with all ultra processed food, which is sort of a silly study to do because obviously, healthy eating index dietary guidelines previously didn't even consider ultra processing. So it just wasn't a relevant metric. But what we've seen happen in our schools, and one reason our kids are so sick, is that the foods there meet the nutrient standards, but they're everything's ultra processed. And therefore it kind of asks, well, what's going on there and how that has an effect. Now, it'll be really interesting. USDA is at the verge of putting out the new school meal rules. This is something else. This is from Dr. Oz. At CMS with the new dietary guidelines. These are his translation of the dietary guidelines into 8 specific points. And they're really outstanding. If this is the 8 points that we get for the dietary guidelines for the school meals, I would say that we may see school meal changes as transformative as happened under Michelle Obama happen again. But it requires, you look here, what's different than some of what the upside down triangle sometimes focuses on. But here, for example, a few bullets down, it says to prioritize proteins, really plant-based proteins. And so I think if you look at this take on the dietary guidelines, if that reflects USDA's take, that could be something that could be very helpful and transformative. Another big area is labeling. So this just came out Colombia. They added the country Colombia. They added a warning label for ultra-processed food. You can see here on the right. Warning labels aren't likely to happen in the U.S. because our Supreme Court believes corporations are entitled to the Bill of Rights and a freedom of speech. So it's hard to force companies to put something on their label. So instead, we're going to see schemes like these. These are non-UPF labeling, a few schemes that are out there already. Some nonprofit groups, California, are all talking about that. And for probably the industry contingent on the call on today's webinar, that's a bit terrifying because they've lived through the non-GMO. Indeed, anyone go to the grocery store, see how many non-GMO labels you see on products and how much that's impactful of what companies do. And if we're going to put that on UPF products, that's going to be extremely difficult to manage. So the companies have worked furiously not to have that happen. One of the ways is to get us bogged down on defining UPF so we can't come up with a label. Another is to get rid of the non-GMO label by changing it to this bioengineered label. Another area of labeling that I'll highlight is, we did the nutrition facts label. I worked on that. We did that most recently in 2016, but the ingredient list hasn't been updated since 1938. And in talking to some of the investigators who are doing all the research now, one of them came up to me and was thanking me for the nutrition facts label because they said it's so accurate. There are ranges, but it really does tell you what's in the food. What they're finding is that the ingredient list is just made up often, that the list here that they're seeing do not reflect what they're finding in the food. And I think that has to do with the fact that the standards haven't been updated since 1938. The best I can tell, FDA is not studying. I think there's going to be a big issue that's going to break soon, is how much the ingredient label does not tell us what's in our food, and is not following any particular standards. And the last thing to touch on is another big area of policy will be the SNAP restriction policies I mentioned before that are now in 22 states. So far, they started off limiting to sugar-sweetened beverages, but with the dietary guidelines, it seems likely that they'll be expanded to all ultra-processed food. And so you'll have states limiting ultra-processed food to people on SNAP, which I think would be a really positive development and a logical extension as the dietary guidelines are rolled out at USDA. And finally, I think the most important policy change that we can make, and I'll end on this, is for the decades that I've worked on this, the federal government's goal in all of its food and nutrition programs is ensuring access to healthy options and information. And the problem is that as a lead policy person overseeing the bureaucrats who go to a supermarket, you go into a supermarket, you see a protein and a produce section, you see food labels, and you say, we've ensured access to healthy options and information. We've done our job, even though we're so sick. And that's just because this goal has failed, and it fails because it really blames us. It says as long as there's some healthy options out there and the information to choose it, food companies are free to populate the shelves with whatever they want. And that really should not be what we do. And so what I advocate for and my group advocates for is replacing that goal with this goal, which is ensuring every child reaches age 18 at a healthy weight and in good metabolic health. And if that were our goal, we would all agree right off the bat that we are failing and we need to try different strategies. And that's what we need to do here with policy at UPF. And that's it for me.
Thank you so much, Professor Mand, and thank you to all the speakers. Excellent presentations. We've learned a lot through the presentations. So I see there's not much time. We'll get to the questions as quickly as we can. Very quickly, if I were to summarize, basically we learned a lot about the nuances in identification of ultra-processed foods, population level disparities in UPF consumption, associated health outcomes, overview of hypothesized mechanisms, challenges in identifying the causality, metabolomics research and policy developments, and efforts related to UPFs. So we do have lots of questions. We'll get to as many of them as possible. I think let me start with the first question. Okay, so much of the evidence linking to ultra-processed foods to adverse health outcomes is observational, which is what we heard from our speakers. How strong and consistent is the evidence from randomized controlled trials for associations with chronic diseases such as obesity, diabetes, cardiovascular disease, and cancers? And what does the current evidence tell us about the role of specific food additives in these outcomes? Perhaps I can ask Dr. O'Connor to start.
Sure, that's a multi-part question. Let me start with food additives, and then you might have to remind me what the first part was.
Sure.
So food additives are very, very difficult to study because, again, it's one component of, it's one chemical of the food, so there's, how do you control for that? What is your comparison? To my knowledge, there's not much human data on food additives unless it's used for regulatory purposes, and Jerry would be able to talk more about that. But food additives is very difficult to study, especially in epidemiology, because again, the way that we ask about what people are eating, you can't tease out that food additive. The most important thing in food additive research is that the doses are not supraphysiological, meaning that they're realistic doses. A lot of the cell studies and animal studies that show negative consequences of additive research are at doses that are not physically possible to be consumed by humans. This is also the case with a lot of artificial sweetener animal models as well. And so we want to make sure that we're using We're investigating doses that are translatable to the actual human dietary pattern, and that we're not creating fear around something that's not, a study design that's not really translatable to humans.
Thank you. I think instead of getting to the other part of the question, since we have a little bit of time, let's get to the next one. And I'm looking at some questions in the chat, and one of the interesting questions, which is perhaps on many of our minds, is especially this question came in, I think, when you were talking about, Dr. Mehta, when you were talking about the classic NIH study, ultra-processed foods versus unprocessed foods. And the question here is, how are researchers able to determine that it was the level of processing rather than sugar, sodium, or fat content that contributed to the disease?
I think this goes back to what Dr. O'Connor was saying. It's really hard to tease these things apart. We really can't. And this is why most of the research, we just say ultra-processed overall. And within that definition, we include the saturated fat. But having said that, I think what Dr. O'Connor said is so on point. There are so many studies going back. We're looking at ultra-processed food as this big group. But looking back, we have plenty of data on saturated fat. We have plenty of data on added sugars. So if we look at that individually, it all makes sense. It all makes sense. But at the same time, we don't know what the effect is of just saturated fat versus saturated fat stacked on with added sugar, stacked on with food additives, stacked on with food dyes. And I think that's the hard part that for us to know. And to go back to your question on can we answer that with clinical trials, it will be really hard as well. And first of all, because we cannot tease it apart, but also because clinical trials are probably just weeks or months, but these conditions take years to develop. So we cannot have a trial of 30, 40 years and waiting until somebody finally has a cardiovascular event.
Thank you. Another question. This is to Dr. Madai. Could you tell us about the efforts to overcome confounding, especially social demographic, beyond multivariable models in studies of UPF and health outcomes? Example, are there studies in countries in which UPF intake is associated with higher SES versus lower SES?
That's a really good question. Most of these studies, if not all of these studies, do full adjustment on any possible confounder that we know of and that we have data on, including socioeconomics. So this is adjusting and controlling for those things. One important confounder that we adjust for is also overall diet quality, which Dr. O'Connor alluded to. So we are trying to figure out and tease apart, is this within the context of just poor diet quality overall, like low consumption of fruit and vegetables, or just this part, or is across the board? And what we see is that it's mostly across the board, but more prominent within the context of low quality diets. So this kind of speaks to that interaction between the additives or the UPF components and the low nutritional value of the overall diet. But most of these studies are fully adjusted, including for social demographic.
Thank you. I think given the time, I'll just get to two more questions. Next question is to Professor Mand. What type of policy approaches are most promising? For example, labeling, taxation, marketing, restrictions, procurement standards to reduce UPF consumption, and what lessons can be drawn from the tobacco policies? If you could keep it brief, though. Thank you.
Sure. Well, tobacco is a great example. I had the privilege of working on those regulations when I was at FDA as well. And it's an area where U.S. Leads the world in public health. When we were working on it back initially, it was 1/3 of young people in America smoked. And today it's less than 2%, an enormous success. Today, as I noted, 1/3 of our kids are sick with a food-caused chronic disease. And knowing the playbook from tobacco, some of the examples you gave work well. And so number one is taxation. If we raise the price, we put taxes on ultra-processed food, other unhealthy food, high taxes, not just a few pennies, but with tobacco, often it was at least $1 a pack increase. But that's hard to do because people worry about the cost of food, and I get that, so that's a tough policy. I think the number one thing we need to do is implement FDA's current laws. So FDA was literally created in 1906 to make sure that processed food and chemical food additives, that was its sole mission, are safe and certainly don't make us sick. And indeed, back then it was one of the 10 leading causes. Today it's the #1 cause of death. And so we need to regulate those foods, and we need to do it by enforcing the 1950 food additives. This idea of GRAS was really never envisioned as something other than some things with historical use. All additives added to our food, companies must be required to prove they're safe. They need to present the evidence the food is safe. That is the #1 thing we need to do that will do this. Companies should be put on notice right now that their additives didn't come through that process. The law requires they do that. And starting now, the clock's ticking. They need to present the evidence that their ingredients, not as molecules tested in lab animals, but in the food and the way they use it and intended to be eaten, are safe. They need to do the research. They need to present the evidence. And if not, those ingredients need to be removed.
Thank you so much. I think we have several excellent questions here, but we reached the mark of 12:30. We should have probably kept this seminar 2 hours instead of 1.5 hours. But I want to thank again our speakers, excellent presentations, and thank you for your presentations as well as addressing Q&As. Let me turn it back to Valerie for closing the seminar.
Thank you, Brahma. That was a very engaging Q&A, and I enjoyed all of the presentations. Well done. Thank you, presenters, for joining us today. I hope you stick around for a couple of moments while I go through a couple of brief announcements. First, I want to highlight an upcoming NIH lecture, which may be of interest. First, we have the Robert S. Gordon Jr. Lecture in Epidemiology, which will feature Dr. Anna Navas-Essien presenting on the human metalome, excuse me for that, keys to healthy aging. This hybrid event will take place this Wednesday, May 6th from 2 to 3 p.m. Eastern Time. So it'll be available in person on the NIH campus, Building 10, and via NIH videocast for those joining virtually. And no registration is required for this particular event. Next up, we have our signature early stage investigator lecture series, which recognizes outstanding early career prevention scientists. The 2026 awardees include Dr. Manisha Ball, Dr. Daniel Corwin, and Dr. Michin Wang, who will present on topics ranging from AI in breast cancer detection to pediatric concussion care to reducing PFAS exposure. So these virtual lectures will take place beginning May 11th, 12th, and 15th at 11 a.m. Eastern Time. And you can learn more about these sessions using the link shared here. And we encourage you to also join and support these emerging leaders in prevention research. And almost there. Finally, please save the date for an upcoming PIF Prevention and Focus webinar on June 25th, 2026 from 12 to 1 p.m. Eastern Time. This webinar will be on menopause and the association with dementia risk. Registration details will be shared soon, so please keep an eye out for more information. A huge thank you to my colleagues here at ODP, our ICO partners, the interpreters, everyone on board who has helped to make this webinar possible and run smoothly behind the scenes. Again, thank you, team. And again, thank you all for joining us today. If you have any questions, again, about the webinar series or today's presentations, please feel free to contact us via email at preventionandfocus@nih.gov. This concludes this webinar presentation. Have an amazing rest of your day. Thank you for joining.